Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. Today we'll be talking on one of the another interesting topic which you might see once in a while in your everyday practice. That is tubercular pericarditis and pericardial effusion. You know tuberculosis is very common in India, and you will come across such cases because tuberculosis is common. Primary involvement of the pericardium is rare, but it will be secondary due to either lung or lymph nodes. So you will come across such cases. You can see clearly this is a pericarditis with fibrinous material, and you can see this is more in favor of a bacterial pericarditis, and you can get pericarditis with effusion. So we call tubercular pericardial effusion. So definition is very clear. It is involvement of the pericardium by Mycobacterium tubercle. So organism which is responsible for this is Mycobacterium tubercle. Pericardial tuberculosis can present as an acute pericarditis or with pericardial effusion. Not very common, but once in a while can be with cardiac tamponade, and as a chronic complication, chronic constrictive pericarditis. So most common presentation is acute pericarditis, pericardial effusion, and constrictive pericarditis. Cardiac tamponade is not so common, but you do come across. And as far as the stages is concerned, initially you get a dry pericarditis, or we call acute pericarditis. Then you come across effusion, that is we call effusive pericarditis or effusion stage. These may get absorbed, so it is called absorptive stage. And when it heals by fibrosis, it results into constriction, so it is called constrictive stage, and condition we call is a chronic constrictive pericarditis. And you can see here, mortality rate of acute pericarditis is more than 80% in acute stage, and still more when person goes into constrictive pericarditis. So you can imagine the severity of the disease. Good number of time it is missed. So cardiovascular involvement is relatively uncommon in patient with tuberculosis. It is only in 1 to 2%, but still the person who gets it, mortality rate is very high. But among the three layers, that is endocardium, myocardium and pericardium, pericardium is the most common which is being affected. So cardiovascular involvement is always secondary due to tuberculosis somewhere else in the body, and the most common organ which is being involved is lung. So it is an important complication of tuberculosis. Good number of time it is missed. Diagnosis is difficult and often delayed because of the presentation of tubercular pericarditis. Pericardial effusion is the most common clinical presentation. Usually we detect the person in this stage rather than in case of a tubercular pericarditis. And delayed diagnosis can lead to constrictive pericarditis, where the mortality rate becomes much more higher. Now for confirmation of tubercular pericarditis, there are two words which are being used. Definitive diagnosis, which is a gold standard, where you detect a Mycobacterium tubercle in smear or culture in pericardial fluid, which is extremely difficult. Detection of tubercular bacilli on caseating granuloma on histological examination of pericardial biopsy. This will be possible when you do a pericardial biopsy. By that time it is too late. But presumptive diagnosis is quite important, and it is useful to come to the closest differential diagnosis. That is, tuberculosis diagnosed in another body area in patient with pericardial effusion. So any person who comes with a pericardial effusion and say he has got pulmonary tuberculosis or he has got a tubercular lymphadenitis, etc., you do suspect this pericardial effusion is secondary due to tuberculosis. If in a fluid there is a lymphocyte predominant and there is an elevated ADA, more than 40 unit, it is 1 point in favor of diagnosis of tubercular pericardial effusion. On X-ray chest, if you see pericardial effusion and there is no hilar lymphadenopathy, but on a CT scan, you get mediastinal lymph nodes which will show you hypodense center, matting, and there is a positive tuberculin test. So that is more in favor of tuberculosis. And once you start an anti-tubercular treatment and there is a positive response, that is also one thing which is in favor of tubercular pericardial effusion. So this particular thing can be very helpful, but it is always in a stage of pericardial effusion rather than in case of a pericarditis. So there are two categories which are utilized: definitive diagnosis and presumptive diagnosis. So while you want to make an diagnosis of pericardial tuberculosis, obtain a sample from either sputum, urine or lymph nodes to establish the diagnosis of pulmonary or extrapulmonary tuberculosis by means of AFB stain, or we will call ZN stain, PCR, or by culture. X-ray chest will show you no mediastinal lymphadenopathy, evidence of pericardial effusion. On echo also you can demonstrate that there is a pericardial effusion. And CT or MRI will show you mediastinal lymphadenitis which is matted, which is in favor of tuberculosis. Always check HIV state, because in India HIV is common and in HIV person chances of tuberculosis is very high. If there is a pericardial effusion, check for ADA in pericardial fluid and also check for lymphocytosis. Empiric treatment should be started before diagnosis is confirmed in most of the cases, and particularly in the person where tuberculosis is common and HIV patient. And once you start an empiric treatment and if a person responds dramatically, it is in favor of tubercular pericardial effusion. If possible, pericardial biopsy should be done, and in pericardial biopsy you can differentiate from malignancy, secondary metastasis, etc., and you can confirm the diagnosis of tuberculosis by presence of what we call as a granuloma. We have already told you that you can have different stages we call dry pericarditis, pericardial effusion, constrictive pericarditis, and you can have a mixture of little amount of effusion with constrictive element we call effusive constrictive pericarditis. Very rarely person will present with cardiac tamponade. Etiology quite common, Mycobacterium tubercle, but this Mycobacterium tubercle can be bovine variety or human variety, can be typical Mycobacterium or atypical Mycobacterium. Risk factors which decreases the immunity like HIV, diabetes mellitus, CKD, particularly severe CKD like we call end stage renal disease, low body weight, head and neck cancer, medical treatment with glucocorticoids or immunosuppression drugs, or person who is who has undergone organ transplant and he is on a immunosuppression drugs in rheumatoid arthritis, Crohn's disease, etc. Again, immunosuppression is very, very common, and old age. Plus, there will be many other conditions which also reduces the immunity. Say person is on anti-cancer drugs or radiotherapy, or person who has also got pancytopenia, etc. By and large, the primary focus is from lung or maybe from lymph nodes. The common mode of spread is by bloodborne or sometime by lymphatics. And precipitating factor we have already mentioned, that is decreased immunity. In lymphatic, it is a retrograde spread of Mycobacterium tubercle from peritracheal, peribronchial and mediastinal lymph nodes into pericardium. Protein antigen of bacilli will induce a delayed hypersensitive response. There will be stimulation of lymphocyte to release different factors we call lymphokines, which activates macrophages and can result into granuloma formation. And once there is an involvement of the pericardial layer, it will result into exudation of fluid forming pericardial effusion. So there are different stages: serous effusion, serosanguinous infusion. It will end up with fibrosis and later on into constriction. During serous effusion, there is an exudative effusion which mainly contains neutrophil, and there are a lot of bacteria. But in second stage, we call serosanguinous effusion, there is lymphocytic predominant with high protein content. Now, if this particular fluid formation is little rapid, it can accumulate good quantity of fluid into pericardial sac and can end up with tamponade, which is not very common. But because of accumulation of fluid, right ventricle and right atrium filling becomes poor, and person will start developing symptoms of right side failure. Because of high proteinous material and fibrinous exudate, there will be now fibrosis which will set in. Fluid will be reabsorbed, so it is in absorptive stage. But because of high protein content and fibrin exudates, it will start getting fibrosis, and it will later on even get calcified, which can be detected on CT scan. Now this is a stage where fibrosis can be prevented by using steroids. So steroid will be very beneficial in this stage when fibrosis, or you can start in a stage of serosanguinous effusion so that person does not end up with fibrosis. Once fibrosis sets in and person ends with constrictive pericarditis, he will need pericardiectomy. So you will need surgical intervention. While in this stage, you can go for drainage. Even in this stage, you can go for drainage. But once the fibrosis sets in, the chances of constriction becomes very, very high. And during fibrosis stage, steroid will be benefited. So we already mentioned different stages: dry stage, effusive stage, absorptive stage, and constrictive stage. We already described those particular 4 stages. So fibrinous exudate, serosanguinous exudate, absorption, and constriction. Now, as far as the clinical picture is concerned, in initial stage, good number of time person may be nearly asymptomatic. But once there is a collection of a fluid, person invariably presents with cough because of compression of the surrounding lung structures, dyspnea on exertion, and sometimes even person can present as orthopnea. This will happen when there is a good quantity of fluid accumulated in a pericardial sac, almost producing what we call as close to cardiac tamponade. Person will also complain of retrosternal chest pain. This dyspnea on exertion and orthopnea is very frequently because of even compression of the lung, as well as the person starts having filling defects in right atrium as well as right ventricle. Because of tuberculosis, person may complain of low-grade fever, night sweat, malaise, etc. Palpitation is not so very common symptom, but once in a while person can complain of palpitation. Secondary to tuberculosis, person will also have weight loss. And because there is a right side filling is less, the pressure in the right atrium rises. You will have increased pressure in the superior vena cava and inferior vena cava, leading to congestive hepatomegaly, which will produce right upper quadrant abdominal pain, which is because of congestive hepatomegaly. Liver will be palpable and tender. So fever, tachycardia, low volume pulse. Once there is a good quantity of fluid accumulated in a pericardial sac, you might have a pulsus paradoxus. Because of decreased cardiac output, because of filling of the right side ventricle and right atrium is poor, person will also have hypotension. There will be increased JVP, jugular vein will be full. You can have demonstration of a Kussmaul sign, that is loss of expected inspiratory decline of jugular venous pressure. Also, there will be clinical presentation of right side heart failure with jugular venous being full, and also you will be able to demonstrate Kussmaul signs even in person with tamponade or constrictive pericarditis. Liver will be enlarged and congested, tender, soft. Ascites is invariably present. You will have a bilateral lower limb edema. Pericardial rub will be usually absent once there is a collection of a fluid, but in an early stage pericardial rub may be heard. Because of accumulation of a fluid in a pericardial sac, the heart sounds will be feeble and sometimes it may not be audible also. It is described as nearly absent heart sound. It is not audible because of pericardial fluid. So in presence of massive pericardial effusion and cardiac tamponade, heart sounds may not be audible clearly. On a precordial examination, there will be fullness of an intercostal space. Apex bit will be very difficult to identify on inspection as well as on palpation. There will be increased area of cardiac dullness on percussion. Heart sounds will be muffled, or we say distant, or sometimes even we use the word absent, not audible. We already mentioned liver will be enlarged, tender, soft, and there will be ascites. As far as respiratory system is concerned, below the left side scapula, we call infrascapular region on the left side, there will be bronchial breathing because of the collapse of the lung, and that is described as Evart's sign, which is because of an enlarged heart which is compressing the lung tissue, and that will produce bronchial breathing in left side below the scapula, we call infrascapular region on left side, called Evart's sign. Some of the common signs we already mentioned, but some which are very peculiar, that is right upper quadrant pain, ascites, edema, and hypotension are in favor of constrictive pericarditis. So usually when you go for a vital signs, hypotension, low volume pulse, low grade fever, evening rise of temperature, loss of weight, loss of appetite, person is having low body weight, thin, dyspneic, JVP is raised, Kussmaul signs will be demonstrable. On cardiovascular system examination, pericardial rub will be present only in early stage. Once there is a collection of a fluid, You will be not be able to hear the pericardial rub, will be difficult, and heart sounds will be feeble or distant. In late stage, you can get pericardial knock, particularly when the person starts getting constrictive pericarditis. You will have to differentiate between a high pitch S3 sound and other sounds by using a good stethoscope. On abdominal examination, we already mentioned ascites will be demonstrable and there will be enlarged tender liver which is soft and bilateral lower limb edema. Pulsus paradoxus will be also demonstrable and it will be very commonly seen in case of pericardial tamponade or in case of a massive pericardial effusion. Occasionally in case of even constrictive pericarditis. If at all if rub is heard, it will be best heard in a pulmonary and aortic area. It will be to and fro, so we call continuous, high pitch, character wise rubbing or leathery sound. There is no radiation, no change with respiration. If person holds the breath, rub is still heard. No change with Valsalva maneuver. And if you ask the person to bend forward, the rub will become prominent. And by applying a pressure on the stethoscope, rub will also become prominent. So rub will become faint or disappears as soon as the effusion starts. And heart sounds will be very, very feeble in presence of massive pericardial effusion. We already mentioned three classical stage: effusive stage, constrictive pericarditis, and effusive constrictive stage. In cardiac tamponade, hypotension, low volume pulse, sinus tachycardia, elevated JVP, pulsus paradoxus, diminished heart sounds. Pericardial rub is absolutely rare to get in a cardiac tamponade, and presence of hepatomegaly, soft tender hepatomegaly with bilateral peripheral edema is classical findings. In case of constrictive pericarditis, elevated JVP, wide descent, prominent wide descent, Kussmaul signs, that is paradoxical increase in the venous pressure during deep inspiration, classical Kussmaul signs which will be also demonstrable in constrictive pericarditis, but much better demonstrable in case of cardiac tamponade. Pericardial knock may be heard in good number of conditions in presence of tubercular pericarditis. It is a loud diastolic sound heard on apex and left sternal border. You can also demonstrate pulsus paradoxus, and hepatomegaly will be a classical feature with ascites and bilateral edema. Effusive constrictive pericarditis is combination of tamponade and constriction. So it is characterized by all the four classical signs: bilateral edema, ascites, hypotension, and raised JVP. Diagnosis is done after pericardiocentesis. There will be elevated right atrial pressure, elevated JVP. On a CT, you will demonstrate little amount of effusion is present in some localized area and with calcified pericardium. You can see here, this is pericardial effusion which is demonstrable, and in this picture, you can see pericardial effusion and you can see in some area there is calcification. You can see calcification. So calcification will be demonstrable, calcified pericardium with effusion. This is a slide which shows you difference between cardiac tamponade and constrictive pericarditis. Pulsus paradoxus will be classically demonstrable best in case of cardiac tamponade rather than constrictive pericarditis, but you may be able to demonstrate in case of constrictive pericarditis. Kussmaul signs is much better demonstrable in constrictive pericarditis rather than cardiac tamponade. In ECG, electrical alternates, low volume, tachycardia, is present more common in cardiac tamponade as compared to in case of a constrictive pericarditis. On an echocardiography, calcified pericardium will be more commonly seen in constrictive pericarditis rather than cardiac tamponade. Pericardial effusion is much demonstrable very clearly in cardiac tamponade, but in a constrictive pericarditis with effusive pericarditis, you may be able to demonstrate in a localized area pericardial effusion. Right atrial collapse will be very classical in case of a cardiac tamponade rather than constrictive pericarditis. A very good difference given between two. You will be able to demonstrate on clinical ground, ECG and echo. I've already discussed this particular slide, so I can skip over. So we have discussed this particular part. So in investigation, X-ray chest is helpful. CT scan or MRI is second most important investigation. ECG, echo is another. So if we discuss that way, in an X-ray chest, you will get globular heart, quite a good amount of cardiomegaly. You may have or may not have pleural effusion, and there may be clinical evidence of tuberculosis in lung. On a CT scan or MRI scan, you will be able to demonstrate very nicely pericardial effusion with mediastinal lymphadenitis. On an X-ray chest, you will not have hilar lymphadenopathy. ECG in case of dry pericarditis will demonstrate classical change of pericarditis where there is a J point elevation with concavity upward, ST segment elevation, and you might have a pericardial changes in multiple leads, and in AVR you will have a what is called as a knuckle sign where PR segment is upright and ST segment is depressed with T wave inversion. While in presence of pericardial effusion, you will demonstrate low volume or low volume complex tachycardia, and once there is a cardiac tamponade or good amount of pericardial effusion, you might demonstrate on an ECG electrical alternance, which may not be seen in a constrictive pericarditis. On echocardiography, it is the best way of demonstrating a quantity of pericardial effusion as well as severity of pericardial effusion. It can also separate out localized or what we call as effusive constrictive pericarditis. Even on echo, you can demonstrate fibrin strengths. You will be able to demonstrate even a right atrial collapse and right ventricular collapse. Swinging heart. You will be also able to demonstrate calcification of pericardium. So echocardiography is one of the very important tools which will help you to differentiate different stages and severity. Pericardiocentesis under a echo guided or maybe CT guided, and fluid analysis will help you to some extent. In a fluid analysis, ADA more than 40 and cell count, mainly lymphocytes, high protein content is more in favor of tubercular pericardial effusion. By and large, AFD are not demonstrable in pericardial fluid and culture may not be positive. But demonstrating presence of Mycobacterium tubercle in other area like sputum, urine, or by lymph nodes, from lymph nodes biopsy, you can demonstrate by Jadenstein or by gene expert. And don't forget to do HIV test. Tuberculin test, not much informative but maybe additional proof. So elevated ADA in pericardial fluid, one of the important clue. AFB detection in a pericardial fluid is not common. It is very, very rare. Culture also good number of time it is not demonstrable, but presence of AFB, presence of mycobacterium culture positive and demonstrable by PCR or by gene expert is more important clue if you demonstrate them in a sputum, urine or lymph node biopsy. Pericardial biopsy is not routinely being done, very rarely being done, but when it is done, you can demonstrate presence of mycobacterium by means of PCR or by means of we call gene expert. So pericardiocentesis becomes a very useful tool. It can be utilized to relieve the symptoms because when you remove some quantity of fluid, the intrapericardial pressure is reduced. So filling of the right ventricle will be good, cardiac output will improve. You can remove a good quantity of fluid which can prevent a later complication like constrictive pericarditis. By removing a fluid also you will be able to help to prevent cardiac tamponade. Echocardiographic evidence if there is there for cardiac tamponade, it is a must. We call drainage should be done. If person is having pericardial effusion with hypotension, it should be done. And if there is a presence of pulsus paradoxus with pericardial effusion, you should do pericardiocentesis to prevent cardiac tamponade. So in these three conditions, it will be very helpful. It is also recommended in case where you are suspecting impending tamponade, where person is having severe dyspnea and there is a tachycardia, what we call is a resting tachycardia. That is a clue which tells you that person is heading towards cardiac tamponade. So pericardiocentesis is done for diagnostic purpose as well as therapeutic purpose to relieve the symptoms. By and large, in a classical tubercular pericardial effusion, it is a straw colored and it is also called as a serosanguinous. It will usually have a high cell count, mainly lymphocytes. ADA will be more than 40. By and large, AFB is not detected in pericardial fluid. So very rarely, you can go for a protein serum ratio, LDH ratio between fluid and serum, etc. But these are non-specific. These are called Light's criteria, but they are not very, very specific. What is more specific is demonstration of AFB and culture positive, which will be more demonstrable in sputum rather than in pericardial fluid. You can see that very rarely you detect a AFB organism and culture positive in a pericardial fluid is not very clear. But if it is present, it is 100% specific. But it will take a long time. You can utilize this particular decision tree for diagnosis of tuberculosis, that in a pericardial fluid, if it is ADA positive more than 40, if answer is yes, straightforward you can go for WBC count. If there is leukocytosis, straightforward you can make the diagnosis of tubercular pericarditis. And particularly, we can say that if ADA is positive, in a peripheral smear, if you go for a count, WBC count, leukocytosis and lymphocytosis more in favor. And if say ADA is not high, you go for HIV. If HIV is positive, you can look at the WBC count. If HIV is negative, you can go for non-tubercular pericarditis. But say on a peripheral smear, if HIV is positive and there is a leukocytosis, now again you can utilize same, and if there is a lymphocytosis, it goes in favor of tubercular pericardial effusion. So you can utilize this particular decision tree, it is called. On X-ray chest, you will have a cardiomegaly, which is called bottle-shaped cardiomegaly, calcified pericardium if it is seen, and there is no hilar lymphadenopathy. So if you get dilated bottle shape, may or may not be with pericardial effusion, it will be in favor of a pericardial effusion. Good number of time you get what is called as a cookie sign, Oreo cookie sign. Very clearly demonstrable good number of time. This particular, you can see this sandwich in between. This is substernal, this is pericardial fat. So it is between a lucent area line between the two behind the sternal border. Good number of time you will be able to demonstrate cardiomegaly with pleural effusion. So you might have a pleural effusion good number of time. You can see calcification here. You can see calcification here. That once you get calcification, it suggests that already there is a healing process which is going on. Constrictive pericarditis. On CT scan, you will get mediastinal lymphadenopathy. So mediastinal lymphadenopathy, but no hilar lymph nodes, more in favor of tuberculosis. On EKG, low voltage, tachycardia, electrical alterance and T-wave inversions, more common in case of cardiac tamponade and massive pericardial effusion. This is pericarditis, concavity upwards. You can see clearly concavity upwards, ST segment elevation with concavity upwards in multiple leads, and in AVR you will get a PR segment elevation with ST segment depression, that is called knuckle sign. So that is very clear. You can see here clearly, and good number of time you can say you can get hook sign, that is J wave at J point. And if the pericardial effusion becomes more, you will have a low voltage tachycardia, low voltage and tachycardia. That is very characteristic. And you might have demonstration of incomplete right bundle branch block. Incomplete right bundle branch block. And when you start getting electrical alterance, that is straightforward in favor of cardiac tamponade. Very typical. You can see alternate beat is of a different voltage. On echo, it gives you a very good idea regarding a pericardial effusion. You can see this is a clear-cut fluid collection, echo space, echo-free space between the myocardium and pericardium, that is visceral and parietal pericardium. And along with that, you can demonstrate sometime in some of that what we call as a collapse. This is a clear-cut pericardial effusion. You can demonstrate very clearly free space. So this is pericardial effusion. So it can be clearly demonstrable. Calcified pericardium can be identified. Fibrin strands you can see, and you can see right ventricular collapse suggesting cardiac tamponade. Here you can see clearly the fibrin strand in a pericardial sac, and there is a pericardial effusion. So strands demonstrable is a good sign, which suggests that person will be heading towards constrictive pericarditis. And you can demonstrate what is called swinging heart, and right ventricle collapse also can be demonstrable. So echocardiography becomes a very important tool to differentiate different stages of pericardial effusion. And on CT or MRI, you can demonstrate even pericardial effusion and calcification can be demonstrable. Pericardial biopsy not commonly being done, but one of the important tool to demonstrate granulomatous lesion, as well as you can show by presence of AFB, and you can do gene expert study also in pericardial tissue culture and gene expert study. PCR in fluid and tissue can be done easily. ADA in pericardial fluid, if it is more than 40, it is more in favor. You can also go for interferon gamma testing in pericardial fluid, etc. can be done. Cardiac catheterization is usually useful to demonstrate the severity of the damage, as in case of cardiac tamponade, constrictive pericarditis and effusive constrictive pericarditis. It is mainly to decide whether the person should be undergoing for surgery or not. You should differentiate different etiology of pericarditis like viral, bacterial, autoimmune, malignant. In HIV patient, particularly Kaposi sarcoma, uremic patient, myxedema, etc. Because in each the treatment is different. While in case of tubercular, AKT treatment will give up very good results. Also, there are rare causes like traumatic, aortic dissection, iatrogenic, radiation, connective tissue disorder, sarcoidosis, post-MI, etc. You should keep it in mind. By and large in treatment, it is usually 4-drug regime, and duration of 4-drug regime is minimally given for 8 weeks. That is we call 2 months, and then later on you can give other treatment for minimum 18 weeks, that is we call 4 months, with 2 drugs or 3 drugs. By and large they follow this category. Category 1, it is called 2 months 4 drug, and for 4 months 2 drugs. Steroid is given to improve the rapid resolution of pericardial fluid and to reduce the need for repeated pericardiocentesis, and also to reduce the chance of pericardiectomy, and by doing that you can reduce the mortality rate also. So usually corticosteroid is very frequently utilized if there is a demonstration of pericardial fluid. So by and large 6-month regime is being utilized, 2 months all 4 drugs, and therefore for 4 months rifampicin and Isonex, and prednisolone is given depending upon the stages. By and large, in presence of pericardial effusion, prednisolone should be given. There is also one word, that is in an area where tuberculosis is endemic and you are suspecting clinically tuberculosis, and in case of presumptive diagnosis, anti-tubercular treatment should be started before even you get a culture. And glucocorticoids, they say that in HIV, corticosteroid may reduce the death from all cause mortality, and also requirement of a repeated pericardiocentesis can be reduced. So in HIV patient, corticosteroid may reduce the chances of constrictive pericarditis, and also it can reduce all cause mortality. Only in case of Kaposi sarcoma, you have to think of, there may be a slight increase in Kaposi sarcoma with use of steroid. This is one drawback. So in presence of HIV, you have to keep a watch on Kaposi sarcoma. But there is no effect on repeated pericardiocentesis. So corticosteroid may prevent constrictive pericarditis in all HIV patients. It is usually recommended in HIV patient with high chance of constrictive pericarditis, where there is a large effusion, high WBC count, and early signs of constrictive on echocardiography. By and large, the regime which is utilized is 60 mg per day for 4 weeks. Then you start cutting down 30 milligrams, 15 milligram, 5 milligram, and then stop it. Or you can use a short course of 60 milligram of prednisolone daily, and then you start tapering of 10 milligram day each week for 6 weeks, and then you can stop. Surgical management is usually required whenever the person is heading towards constrictive pericarditis, or there is a clear-cut demonstration of constriction and calcification. or if there is a life-threatening tamponade at any stage where you require to do a complete drainage followed by what we call as a pericardiectomy, or if the person fails to respond to 6 to 8 months of medical treatment and there is elevation of venous pressure. Pericardiectomy mainly done by pericardial window for pericardial thickening and then followed by pericardiectomy, total pericardiectomy. So pericardiectomy is a surgical resection of a pericardium for those who echo finding shows pericardial constriction after 6 to 8 weeks of treatment, and those who remain symptomatic for 6 to 8 weeks after the treatment of 6 to 8 weeks of steroid and antitubercular drugs. All patient who has got repeated echocardiogram after 6 to 8 weeks, you should repeat a echo after 6 to 8 weeks of a treatment with AKT and steroids. And if still there is a presence of evidence of constriction, fibrinous exudates, etc., you should advise pericardiectomy. So complications, most common complication, constrictive pericarditis, cardiac tamponade, chronic heart failure, recurrent pericarditis, and while doing a procedure you can give rise to bacterial infection. So congestive heart failure, constrictive pericarditis, cardiac tamponade, congestive hepatomegaly ending into cardiac cirrhosis is the common complications. So take home message, there are common symptoms like fever, weight loss, cough, dyspnea, chest pain, and if there is an echocardiography suggests tubercular pericarditis, you should go for pericardiocentesis, and if it is ADA positive more than 40, and if it is culture positive, demonstration of AFB with PCR or by gene expert, you should put them on antitubercular treatment and have a good follow-up after 6 to 8 weeks with or without steroid. Tubercular pericardial effusion is always secondary due to primary tuberculosis, and primary tuberculosis is very common lymph nodes and lung. Early detection and management can prevent complications like cardiac tamponade and constrictive pericarditis. Empiric treatment with AKT 4 drug regime for 2 months, then 2 drug regime for next 4 months, with steroid in all HIV patients, or in HIV patient with established constrictive pericarditis where there is a high risk should receive steroid. Follow-up echocardiogram should be done after 6 weeks to evaluate improvement or there is an evidence of constrictions. So I thank you all for taking out time. I know that your time is valuable and I appreciate you for spending some of the time with me. I think once in a while you might see such patient because in India tuberculosis is very, very common. So always keep it in mind. India tuberculosis is common, and if any person who has got history of tuberculosis in past comes with dyspnea, edema, pain in right iliac, right hypochondrium, with ascites, and on clinically if there is an evidence of pericarditis or pericardial effusion, do suspect tuberculosis. So I end my lecture here. I hope this lecture will be helpful to you.